Oui, la directrice va.
The floor to the regional director. Thank you very much. Thank you, Chair. What I would like to say to the distinguished delegates, the ministers, our colleagues, through the Minister of Health of the Republic of Congo, today it's actually his birthday. I was informed of this little secret. So we would like to wish you a very happy birthday, Honorable Chairman. And we'll try to be efficient and manage our time well so that we can celebrate as a family.
Happy birthday, dear Minister. Happy birthday to you.
Maria Fiona.
Maria Fiona.
Dr. Yodi for the facilitation. Bonjour, Dr. Okay.
Welcome.
Congrats.
Thank you.
And yeah, my people will say you sit. They will sit. Yodi will be participating from there.
Is it the one that is there?
We can reserve
Yeah.
Yes. On this one. Maria. Maria.
Salam, you should have been there.
Where?
Where Maria is. You need to be there.
Okay.
Yes.
The protocol asking.
Yes. Of course. If you don't mind.
No, I no problem.
Does she have a name?
Do I have a nameplate? No, I don't.
Okay.
Welcome. Bonjour and hello. Welcome, honourable ministers, distinguished guests, ladies and gentlemen. Thank you for attending this critical meeting. Today we share with you the latest updates on the Mpox crisis as the Mpox crisis continues to unfold across the continent and bring you critical insights from the IMB, Intergovernmental Negotiating Body, as they enter their second year of deliberations, working diligently to forge a global consensus on pandemic prevention, preparedness and response, one we hope that you will all push to help us get done by December this year. A quick background, who am I? My name is Dr. Ayode Alakija. Many of you know me as Yodi or Dr. Yodi. I'm the board chair of FIND, and I'm Dr. Tedros, the World Health Organization's special envoy for the Access to COVID Tools Accelerator, and co-chair the principals group of this body. I'm also co-chair of the Impact Investment Initiative for Global Health led by the G7. The rapid spread of clade 2, clade 1b, coupled with the lack of diagnostics around at the moment on mpox, means that we are walking blindly into a storm. I'm delighted today to be joined by Dr. Tedros. Lovely to see you all, leaders, the President, the RD, and also congratulate our new RD designate. Today we also have here with us experts from WHO Regional Office for Africa, experts Maria van Kerkhove from Geneva, and Africa CDC, the Director General, my brother Jean Kaseya. It's wonderful to have you here. Ministers of Health from DRC, Burundi, and South Africa will be speaking to us today, as will the co-chair of the IMB. It has been exactly 2 weeks since a FEC was declared for mpox on 14th of August. And when the world talks about a 100-day mission, we must consider that this first period is critical for a response. But have we not already passed the 100 days? Have we not already passed the critical time? Is it not past time that we act, and that we act now, and that we act together? We understand that there are many things going on, re-vaccines, but I must also remind us here in Africa, as you heard excellently from the experts earlier today, that we are used to outbreaks, we are used to epidemics, and we deal with them so much better than the rest of the world. The world should be coming to you, my honourable ministers and friends, to learn, not telling us what to do. And so I'm hoping today we're going to hear from the experts around this table. We're going to hear from you, the ministers of health, who do the hard work, many of your technical teams who do the hard work around the world. That work you feed up to the global level, to Geneva, to my friends in Dr. Mike Ryan, DDG's team, to Maria and all of their teams, to the Director General. But really, the work is done by you, all of you around this room. So I'm hoping that over the next 90 minutes or so, we're going to get some serious work done. We're going to get some work done that will advance the mpox response around Africa, and we're going to get some work done that will ensure that the IMB gets done by December this year, with equity at its core and making sure that we truly are dealing with the people who are suffering the most, those who are most affected by these crises. So we're going to talk about a plan. We need input from member states. I understand that there's a plan being put together with colleagues both from WHO and Africa CDC. We need input from US member states. We need a clear description of the agreed modalities for the implementation of these plans. And without further ado, as I close, I'm going to say that we as Africans must be masters of our own destiny. Mistresses, as I see many female ministers here and many of my sister ministers, of our own destiny. As we break the old paradigms of being reliant on handouts from the global north and work for our own self-determination, we must also continue to play our own role in the multilateral system, contributing our unique perspectives on our voices. Critically, we must be clear on how we manage the dichotomy of regional and global cooperation without impinging upon national sovereignty, because indeed you all come from sovereign nations. Countries have sovereign rights which cannot be wrapped into regional bodies or wrapped into international bodies. We stand alone, even as we stand together. The lessons of COVID-19 have taught us that at the end of the day, negotiations for medical countermeasures and distribution is a very national affair. So as you ministers speak today, we must respect your sovereignty and find ways for regional cooperation without throwing away national rights, either to the global community or to regional bodies. This is a fine balancing act we must play, and we must play to find a balanced solution, since our very lives depend on it. I am now inviting Dr. Jean Kaseya, Director General of Africa CDC, Dr. Mashishido Rebecca Moeti, the Regional Director of WHO Afro, not quite emeritus, and Dr. Tedros Ghebreyesus, WHO Director General, to open the proceedings and lay the foundation for discussions that will unpack critical challenges and concerns on the mpox response, as well as an update on next steps in the IMB. Dr. Kaseya, my brother. over to you.
My sister, Dr. Ayuade, thank you so much for giving me this opportunity to address Their Excellencies, honorable ministers here present. Dr. Tedros, my brother, I have to call him my big brother, the Director General Africa CDC. Now, yesterday I heard that Dr. Mweti is Regional Director forever. I don't know if this title exists, but I will check with the legal people. I will start to call you. Colleagues, this is a great honor for me and a privilege to be with you and to address all of you about some critical issues that we are facing in Africa. This meeting is being held at a critical moment with the mpox declared as a public health emergency of continental security on the 13th of August by Africa CDC and public health emergency of international concern on 14th of August by WHO. The mpox disease is increasing over the past few months, and based on the data we collected from countries on the 27th August, we have 22,863 suspected cases and 622 deaths. You will see we are talking about confirmed cases, but we are not talking too much about it because we still have countries with a testing rate below 20%. And we still have countries facing a number of challenges in terms of quality and transportation of samples. It's also another area where we need to make a lot of effort. Excellencies, dear colleagues, we don't have one outbreak. We have multiple outbreaks in one. If you consider the number of clades that are circulating currently. And to give you an example, when in Europe they had to use tecovirimat to fight clade 2 in 2022-2023, a study conducted by INRB in DRC, NIH, and other key partners shows that tecovirimat is not effective, cannot support the response in Africa, especially in countries facing clade 1. Let me give you also a kind of background on the declaration of mpox as public health emergency of continental security, which was a historic milestone in the journey of Africa CDC. As you know, this is not just a political declaration. We had to follow, based on the Article 3, paragraph E of Africa CDC statute, we had to consult a number of technical, strategical, and political people to make this declaration. We had a group of 16 African experts under what we call the Emergency Consultative Group who came together and advised the Director General Africa CDC to declare based on data that were available. But let me remind you, because we need to be proud as Africans, out of 16 people, 7 of them are also members of the WHO Emergency Committee in Geneva. The declaration will enable us, as Africa, to mobilize resources across affected countries, but also high-risk countries. Because when we started to talk about it, we had only 7 countries. Today, we have 13 countries affected. You have to consider that all of you can be affected if we don't put in place strong measures to stop this outbreak. This is why we need to unlock funding. We need to unlock medical countermeasures. We need To strengthen the communication and community, risk communication and community engagement, we need to boost surveillance, and we need to make sure that we have the testing ability and human resources to proceed with this testing. We say that, we repeat it, Mpox is a zoonotic disease. If there still are the people who are doubting to implement One Health approach, I hope and I think this is opportunity to say Africa needs One Health approach. Excellencies, colleagues, dear friends, please let me thank Dr. Tedros. Let me thank Dr. Tedros because even if WHO Geneva declared the public health emergency of international concern, but is letting Africa managing this outbreak. And let me tell you, we are coming together to manage this outbreak. Africa CDC is bringing the political and strategic mandate, and WHO at regional level is bringing the technical expertise. This is why we are co-creating for the first time, and this is historic in Africa, one continental incident management team. We are co-sharing this continental incident management team, Africa CDC WHO. It means countries will not be confused by seeing WHO and Africa CDC coming together, co-sharing this response. This is why also we decided to have one continental response plan. When we talk about one continental response plan, it means it's what we got from African country members, mostly affected by Mpox, plus technical assistance from partners. Then we have one plan that will be presented to you. Dr. Mweti, my sister, and myself, we are on daily basis leading that. We are on daily basis in contact with Dr. Tedros for some strategic areas like procurement of vaccine. Let me share with you some good news. Today, we are moving towards securing almost 1 million doses out of the total we need. We managed to secure 215,000 doses from Bavaria Nordic in partnership with European Union under ERA. You saw me 3 days ago talking with the French State Minister to unlock these 100,000 doses from France, almost 100,000 doses from Germany, and yesterday I was talking with my sister, the Minister of Spain, about the 500,000 doses from Spain. We are moving because we cannot accept to see Africa lacking vaccine to respond to this outbreak. More than that, local manufacturing, we cannot stop it. We are still not prepared for another pandemic. This is why we clearly say to Bavaria Nordic, we need the tech transfer to African manufacturers. We started with 9 manufacturers. Currently, we have 1 selected based on the ability to manufacture vaccine. We believe that very soon, the Mpox vaccine will be manufactured in Africa.
Excellent.
I can't stop without talking about the pandemic agreement. Ladies and gentlemen, we are talking about the next pandemic. We are thinking that it can come in the next 5-10 years. Mpox is a major alert for us. And we see we are not prepared. This is why we need to finalize the pandemic agreement. This is why we are calling our partners from Western countries to come to continue the positive engagement, and Africa CDC will be there to support all member states to finalize this agreement. I believe if we finalize the agreement, I believe if we move forward with the local manufacturing, I believe if we strengthen our surveillance, Africa can be secured. I thank you.
Thank you very much, Dr. Kaseya. Africa can be secure with the work of all of us, with the work, combined work. It's great to hear you talk about Africa managing its own part of the current emergency with political and strategic mandate of Africa CDC, and recognizing the technical expertise of WHO, who of course has staff in country offices all over the region. It's wonderful to talk about the One Continental Management Team and also the vaccination doses. But I must also remind you all, as I hand over to Dr. Moeti, that we can't have another vaccine-based strategy. We must do primary health care. We must do the basic things. It is not just about vaccines. I look at my brother, Minister from Nigeria, Pate, and congratulate you on the 100,000 doses that were the first to arrive in Africa, which arrived in Nigeria in just a couple of past 2 days. Dr. Moeti, over to you.
Thank you. Thank you very much, my dear Sister Yodi. So, honorable ministers, the Director General of WHO, my brother Dr. Tedros, Dr. Kaseya, the Africa CDC Director General, distinguished colleagues, friends, ladies and gentlemen, I'd like, on my part, to welcome you to this special briefing session on the Mpox public health outbreak in Africa. And also, we'll be providing updates on the intergovernmental negotiating body, INB. I very much appreciate your interest in both. You know, if you look at the program of this regional committee, and I'll promise I didn't do that because it's my last regional committee, there were so many important issues to discuss. The program is very full. We have a side event every morning, at lunchtime, and every evening. But we thought, as we were finalizing the program, that the matter of this outbreak of Mpox was so important that we had to change our initial idea of having it as a side event squeezed into a break and incorporated it into the main agenda as this special event, because we wanted to be sure that all the delegations would be free, all the partners would be available to be with us. And of course, we are very happy that we're able to do this jointly with our colleagues in the Africa CDC, because it is that important as an issue and as an illustration of all the efforts that we are making together to improve preparedness and response to epidemics, to pandemics on the African continent. I'd like to start on a positive note, just reflecting the discussion at the previous session, where we were able to demonstrate that if we invest strategically in certain capacities, and I was happy to hear this confirmation from the member states who took the floor in large numbers, which is why we are running late on our program, that you are starting to appreciate that investing in human capacities, investing in capacities to manage, analyze data and have information in real time, investing in ensuring that supplies are there on time, actually is making a difference. So I'd like to start by saying that we're facing a serious challenge with this outbreak, but we've already started to see a change in capacities in the countries, including having the surge capacity of experts that we are using to support responses within the countries and even to go internationally. So I'm hoping that we're taking this discussion in a very positive, increasingly self-confident note, indicating that we're facing big challenges, but we're doing things to address the capacity gaps on the continent, and working together, we can arrive at a point we'll be able to face up to pandemics. So thank you, just because I didn't speak at the end of the last session, for confirming that what we are doing to improve the capacities in countries is reflecting your needs, and we will work together with you, together with our colleagues at the Africa CDC and our headquarters, to consolidate those capacities, so that we can face up better to Mpox and to other pandemics as they confront us. It's already been said that at the global level, WHO is leading efforts to combat the ongoing Mpox public health emergency, which was declared by Dr. Tedros a couple of weeks ago. We're seeing, as my colleague said, different outbreaks take place in different places. So I'm hoping as well because I'm an eternal optimist, that we can, while acknowledging the gravity of the situation, put the whole story into its perspective. You know, just before the start of the regional committee, I got a message from a leading person in public health who asked me, why are you convening an in-person regional committee in the face of this mpox? Why don't we have this meeting virtually? So first it was like, okay, we're going to elect the regional director. Very difficult to do virtually. But it was also forcing one to think about putting this into perspective. And as my colleague said, we have different disease outbreaks. We have the epicenter in the eastern part of the Democratic Republic of the Congo, and it has spread to Burundi and other countries. We have outbreaks having happened in other countries. We have endemic situations in a number of countries. And we have also leftovers of the global epidemic that happened in 2022 in some countries in Africa. So in my view, we need to work together to understand each of these situations and apply the appropriate responses as deserved, and then enable preparedness to be strengthened, border collaboration to be strengthened, systems to be put in place in case needed in the rest of the countries, and enable normal life to continue even as we mobilize a response to this pandemic. So that's very much my second message. I'd like also to share some information on the work that we are doing at the country and regional level in WHO, because after this, my boss, Dr. Tedros, is going to speak about the measures that are being taken at the global level to altogether help address the risk and the reality of this mpox outbreak. So we're focusing a lot of our response efforts in countries with confirmed mpox cases initially, taking proactive measures in high-risk countries within borders of affected areas. We think that this is a critical part of our strategy to prevent the virus's spread across borders and contain outbreaks before they spread and escalate. In the affected countries, we have been working very hard in developing mpox treatment guidelines and extensive training programs for healthcare workers focusing on the clinical management of mpox. These trainings go beyond providing basic care. They involve identifying, treating, and caring for patients, particularly managing severe cases and providing much-needed psychological support to patients and their families. We learned during the COVID-19 pandemic how important that is, and it's an aspect that we need to incorporate into everything that we do as we help in the response to disease outbreaks. I'm very glad to say that we are leveraging COVID-19 capacities to scale up the mpox response. For instance, since the COVID-19, we now have all countries capable of carrying out PCR testing for mpox. And this week, we're collaborating with the Institut Pasteur in Dakar and WAHO, the West African Health Organization, to conduct diagnostics and sequencing training for mpox. We've seen already in the response that there is a need to decentralize testing. So we are needing to look, we've been looking at technologies like GeneXpert, technologies that can be used at the peripheral level in addition to PCR, and we are working within countries through our country teams and the experts that we have deployed in countries to build and increase this capacity. We've supported our member states in operationalizing dedicated treatment centers and isolation units for patients to make sure that these are adequately staffed, monitored, and equipped. In addition to targeted efforts for affected member states, we're making comprehensive arrangements to make sure that every country, regardless of its current situation, is equipped with the necessary tools, knowledge, and support to respond effectively if the need arises. We all know that we must prioritize vaccines reaching those who are most vulnerable. We've been very much in the forefront of vaccine readiness and have developed an mpox vaccine introduction readiness assessment tool, which will ensure that we have targeted vaccine deployment plans. This readiness is critical as we engage with other partners to secure vaccines, and I'm sure that the Director General is going to share what he has done at his level to make sure that we are getting the vaccines that are needed. Cumulatively, our efforts are geared to ensure that our response is quick, scientifically sound, enabling us to detect, diagnose, and respond to mpox. At the regional level, the most vulnerable to public health emergencies, as this region is most vulnerable, has already been said, to public health emergencies, we know that this won't be the last time we deal with an outbreak of such proportions and of such risks, and we will continue to work on this. I'd just like to end by saying, as happened in the past outbreak, we are starting to see pushback in misinformation around mpox, including the need for vaccination, yes or no, and say that we had a very strong platform of addressing misinformation in the region during the COVID-19 pandemic, and we are restarting that work that we are doing, the infodemic response, to make sure that we gather the right information, we monitor the misinformation, and we provide the support to counteract it as much as possible. So I look forward very much to working with our colleagues in the Africa CDC within our joint emergencies action plan, and of course with the support of our headquarters, to help you, honorable ministers, to address the risk and the outbreaks within this mpox situation. Thank you.
Thank you very much, Dr. Moeti, for that comprehensive overview of what is being done at country level, at a practical, technical level. Of course, as board chair of FIND, which works with you all on diagnostics, I'm delighted to hear that diagnostics and testing is very much on the forefront of this response, and that you're actually actively working with African institutions to push this agenda. And without further ado, it is my honor and my privilege to welcome Dr. Tedros to give his remarks.
Thank you. Thank you, Erdi. Thank you so much. Honorable ministers, members of delegation, and my sister Shidi, and my brother John, dear colleagues and friends. Mpox is not new to our continent, and it's not new to WHO. For years, WHO has been supporting affected countries in our continent to respond to sporadic outbreaks of mpox. And for years, we have been calling for more research and for the development of diagnostics, therapeutics, and vaccines for mpox. We see now it's attracting the attention of the international community. As you know, 2 weeks ago, declared a public health emergency of international concern over the outbreaks of mpox in Africa. This is the highest level of alarm under international health law, as you know. My declaration is completely aligned with that made by my brother, John, the Africa CDC Director General, the previous day of a public health emergency of continental security. By the way, this is historic and done first time, and the continental and global declarations actually reinforce each other. John and I have spoken frequently to ensure our two organizations are working together closely to leverage our comparative advantages and to coordinate our work under one plan with one budget, as John had already indicated earlier. As a side note, I'm proud to say that I actually proposed the idea of establishing the Africa CDC at the Abuja African Union Summit in July 2013, when I was Minister of Foreign Affairs of Ethiopia. So I'm very glad to see how my daughter, the Africa CDC, has grown and is now co-leading the response to mpox with WHO. So from the proposal, it's 11 years, WHO is 76 years, now we are co-leading. And I'm really glad to see that. And credit also to all member states of the African Union for establishing the Africa CDC. And in accordance with the IHR, I issued temporary recommendations last Monday for countries at risk. And I have also extended the standing recommendations that I issued last year for all countries. On Friday last week, we shared our global strategic preparedness and response plan to stop human-to-human transmission and bring these outbreaks under control. And I am confident that Mpox can be stopped if we work in unison under the leadership of you governments. On Friday, we received the information we needed from the manufacturers of both vaccines to evaluate their products for emergency use listing. We expect to be able to issue that listing within the next 3 weeks. In the meantime, I have given the green light to Gavi and UNICEF to proceed with procurement of vaccines pending the EUL decision. It's vital to stress that although vaccines are a powerful tool, they are by no means the only tool. There are many other things that WHO, the Africa CDC, and our partners are doing to stop outbreaks and save lives. And I think Shidi had already indicated, and also John, some of the things we're doing, and I don't want to repeat that, but with test PCR missions, with supporting labs, scaling up workforce, and training health workers and supporting clinicians, working with local partners, civil society, and engaging affected communities, starting from the design, implementation, and so on, much more. And the last thing I would like to say is, the Mpox outbreak is another reminder, if any were needed, of the critical need for a legally binding international agreement to ensure a coordinated and equitable response to pandemics. As I did in my opening remarks on Monday, I urge all member states of our continent to engage actively in the work of the International Negotiating Body, IMB, and to complete those negotiations by the end of this year. I thank you, and Yodi, back to you.
Thank you very much, Dr. Tedros, and congratulations on your daughter's coming of age. We are proud that you helped birth this baby and happy to see that the baby is now growing up into an adolescent. Dr. Tedros has just reminded us that Mpox is not new to our continent. Dr. Tedros has just reminded us that it is only when it began to spread to the rest of the world that the world started to take notice. Dr. Tedros has reminded us that the tools are available, but they're not always available for us. Dr. Tedros has reminded you, Your Excellencies, that you have an incredibly critical role to play, not only in stopping this current outbreak, which we can and must stop, but also in ensuring, as my dear sister Precious Matsoso, the co-chair of the IMB, will speak to later, that we have a clear and binding pandemic agreement by the end of this year, I add. And so, having heard from what we call in Nigeria the ogas at the top, I will now take you to my colleagues who are going to give us a technical update on Mpox. We're going to hear from WHO and Africa CDC, this wonderful partnership, about preparing, detecting and responding, a blueprint for tackling Mpox. Dr. Maria Van Kerkhove is the Global Mpox Incident Manager. She is the lead person in Geneva in charge of corralling us for the ACT Accelerator. A dear sister, a dear friend. Maria, I welcome you.
Good afternoon, colleagues, excellencies, Director General, RD, DG of Africa CDC. It's a pleasure to speak with you today. If I could ask for the slides, please. There will be three of us that will give a brief overview of the current situation globally, as well as focusing on Africa. Next slide, please. We first put this into context. So what you'll see here are two maps. On the right-hand side are the numbers of countries that have reported Mpox cases since the beginning of 2022. And on the left-hand side, you will see the countries that have reported just in the month of July alone. So while we had a public health emergency of international concern in 2022 and 2023, largely led by this clade 2 virus, that was brought under control with concerted community action and a number of different interventions. But the virus continues to spread. Next slide, please. What you will see, and you will hear more about this from my colleagues, is that the recent upsurge of Mpox is what led the Director General to announce a public health emergency of international concern. What we have here is a focus on the DRC, but also neighboring countries, some of whom have never reported Mpox cases before. You've heard from our three opening remarks that we are looking at in a challenging situation of surveillance. We don't have full visibility on the epidemiology and the spread of these viruses. The concern that we have is not only the increase in cases, but this new clade 1b, which is circulating in the DRC, but also in neighboring countries, most notably in Burundi. Next slide, please. So you've heard this from all of our speakers so far. What we are working towards is a global coordinated action with WHO, with all of you, with Africa CDC, with all of our partners. Not one of us does this alone. So you already know that the public health emergency of international concern was announced on the 14th. We've had the announcement from Africa CDC the day before. This is an evolving, it's a dynamic, and it's a concerning situation, and things are changing. We are doing our best with all of you to better understand what is unfolding so that the response can be precise, it can be tailored, and that the resources that we do have, we can use focused on the people who are most at risk. So a global strategic preparedness and response plan was presented to member states last Friday. We have a significant scale up in affected countries, and with thanks to all of you and to your workforce who are on the ground, who are addressing this. And for us, as always, partnerships are what is successful and what will be successful to stop this outbreak. Next slide, please, and this is my last. I wanted to highlight one aspect because as you've heard already, there's a lot of attention right now on vaccines. And of course, vaccines are important, but they are not the only control measure that we have. The global outbreak in 2022-2023 was brought under control by communities, by engaged communities who were informed, who were part of the response, who were part of the development of these interventions, and actually the use of these interventions. On the side of access to countermeasures, this covers many different components, not only guidelines and policy, but looking at research and development. And tomorrow and Friday, there will be a global R&D meeting that will largely be virtual. You are all invited, which is brought together by WHO, by CEPI, by Africa CDC, and others to make sure that we look at what are the latest priorities that we need across research and development. We are working on developing an ICG-type mechanism for the donations that are coming in, which you are hearing about, as well as their delivery. Again, vaccination needs to be used in a targeted way. We will not have enough vaccine to be able to be used for everyone. We have to focus on the at-risk groups. And there's a lot of work happening with regards to the supply chain management. Underscoring this is the regulatory approvals, and you've heard the Director General say that EUL is being used, and we hope to have answers on EUL in the next couple of weeks. So when we talk about countermeasures, we're not just talking about vaccines, we're talking about therapeutics, we're talking about diagnostics, as well as other health products. Dr. Fiona?
Dr. Fiona Bracker, Emergency Response Manager, who's in charge, you've just all heard from WHO Afro. Fiona, over to you.
The Director General, Dr. Tedros, Dr. Moweti, DG Dr. Kasea, Your Excellencies, I will just build on with a focus on the African region and what's happening with the outbreak as well as the response. So we are witnessing the increase in cases, as has been mentioned already, since early 2022. And in just the first 6 months of 2024, we have witnessed more than 4 times the number of cases compared to the same period in 2023. The surge is majorly driven by the outbreak in DRC, which accounts for 90% of the cases that have been confirmed. We'd also like to highlight that beyond the cases that are confirmed, there are thousands of suspect cases, and the testing capacities are limiting our understanding of the true burden of the disease. 24% of those suspect cases have been tested, and what's concerning is that over 60% of those that have been tested are actually positive for Mpox. Next. This shows the geographic spread comparing 2022 and 2024. In 2022, we had 19 countries. 16 of these are in the WHO Afro region. And as of 2024, we have 13 countries in the WHO Afro region that have recorded an Mpox case. Although the epi situation is not fully understood, what we do know is that we are seeing 2 distinct outbreaks in the DRC. The clade 1A is affecting majorly children in the routinely endemic Mpox provinces and regions. And then the second outbreak is related to the clade 1B, which is the new strain that has emerged. It is spreading through majorly to adults in the eastern provinces of South Kivu and North Kivu. The data indicates that it is spread majorly through sexual contact, especially among networks of commercial sex workers and their clients. The surge in DRC is of a further concern because we have seen it spread geographically to Burundi, to Rwanda, to Uganda and Kenya in the last couple of months. These outbreaks are linked to the clade 1B outbreak in the DRC. In addition, we have reports of cases in Sweden and Thailand, again linked to the clade 1B strain. This strain also is particularly concerning because of the severity, especially in immunocompromised individuals as well as children and pregnant women. Just to highlight, next slide, the key takeaways in terms of the epi situation. We have a dynamic situation that is evolving with additional countries that have reported their first cases in 2024. The total number of countries affected has risen to 16 for the WHO Afro region since this outbreak started in 2022. And we are seeing confirmation of the clade 1B strain beyond DRC to neighboring countries, and particularly also concerning is the growing outbreak in Burundi. The limited surveillance and testing capacities, diagnostic capacities, complicate the understanding of the true burden of the outbreaks and hindrance to the response to the outbreaks. Our next slide. Our Director General has noted the standing recommendations that were issued in August of 2023 and have been extended for an additional year to August of 2025. These recommendations are for all state parties and they focus around next slide please. They focus around seven major areas, and they are in accordance with the international health regulations. Next slide. The Director General also highlighted the temporary recommendations that have been issued in relation to the public health emergency of international concern. These have been issued to state parties at risk We'd just like to emphasize that they are complementary to the standing recommendations and that they are specific and targeted around 9 key thematic areas. These have been shared with member states and are also available on the web. We would like to, next slide, commend the great effort that has been underway by affected countries and countries at risk in trying to scale up the capacities as well as response interventions. We thank you for all the collaborative work that is going on, and we'd just like to highlight some of the scale-up interventions that are underway that we are working with you to support in this response. In the DRC and Burundi, we are surging up capacities. We have over 400 repurposed staff and consultants that will be working with the 2 countries to scale up the response. And we are also working with the other affected at-risk countries to finalize their plans and ensure we have the necessary surge capacities to respond. In the DRC, we have 9 subnational offices that are being strengthened to facilitate coordination. Thanks to the investments in COVID-19 response, we have pre-positioned supplies that were available at the Nairobi hub with the support of USAID majorly, and these have been disbursed to 5 countries in the region, and work is underway to increase those supplies, especially around the testing, the supplies needed for testing. A push order of about 2,500 Mpox tests per country is in the pipeline for 8 countries and should be arriving soon. We have conducted on-site visits and training in 45 countries to facilitate expansion of genomic surveillance. We are pleased that with the investments in COVID, all the countries in the region have PCR testing capacities, and we are building on those capacities to further increase and improve our diagnostic and sequencing capacities. As we speak, there is a training that is going on at IP Dakar this week in collaboration with WAHO and WHO to provide, strengthen those capacities further among the lab personnel. And we are working to establish a network of regional reference laboratories across Africa. A lot of work around clinical care management, the guidelines, as our DG had mentioned, have been provided, and capacity building has also been provided to train health workers in the clinical care of Mpox cases. My last slide is highlighting also in terms of financing. We have released $1.5 million from the contingency fund for emergencies, and an additional $2 million is currently under review, which we hope will be approved. And all this funding is majorly supporting the response initiatives at the country level to scale up the response. A lot of work around surveillance intensification. If we do not monitor, if we do not report, we are not able to respond promptly. So we want to thank you for the integration of Mpox surveillance within the IDSR framework that is already existent in the countries, that is helping us to be able to report and monitor the outbreaks. There is a lot also going on to prepare the countries for vaccination, particularly DRC, South Africa, and we had also Nigeria yesterday has received some vaccines. So the planning around identifying high-risk groups, the work around vaccine regulatory processes that has to go hand in hand through the African Vaccine Regulatory Forum. We are working with 13 high-risk countries to support the authorization of these vaccines through the emergency use listing, should that come into effect soon. We also are working with the national immunization technical advisory groups to ensure that there is evidence-based information available to guide the decisions around vaccine introduction. Our regional director talked about the infodemics, the information that is out there, the misinformation. And a lot is being done, thanks to your support, in ensuring communities are sensitized, the media is sensitized. We've worked together around orientation of journalists and also community-level sensitization to provide the necessary information, but still a lot more needs to be done. For those that have not reported cases, we want to emphasize the need for readiness, ensuring that the capacities are in place. We have worked with countries to conduct readiness assessments through a self-assessment process. The tools have been distributed to countries, and so far we have received responses from 18 countries, and feedback has been provided. We want to highlight the overall readiness from the countries that have responded is around 50%, and this average is pulled down majorly around components related to vaccination, to supplies, and to coordination. So we need to continue to work to build those capacities and be ready in the countries to respond effectively. Honorable Ministers, I thank you for your attention.
Thank you, Fiona. And I'd like to now welcome Dr. Ngashi Ngongo, who's the Chief of Staff and MPOX Incident Manager for Africa CDC. Dr. Ngongo, over to you.
Thank you very much, Madam Chair, Your Excellencies, members of the delegations, Director General Dr. Tedros, Director General Dr. Jean Kasseya, RD, distinguished guests. I'm going to present the Continental Preparedness and Response Plan for Mpox outbreak in Africa, which is a 6-month plan developed through a very inclusive process that involved all the 13 member states that are affected now by Mpox, together with the key partners and the 16 members of the emergency consultative group that were really invited also and have provided very constructive feedback into this process. I have to say that this is the first time that WHO Africa CDC are working in this very well-coordinated manner to produce one single continental plan that includes the activities of the member states together with the technical assistance of the partners in a way that can facilitate transparency, synergy, efficiency, and accountability. The overall goal of this plan, next slide, is naturally to stop the transmission of the Mpox virus in affected member states, but also support preparedness and prevent the spread to the non-affected member state through a continentally coordinated approach. Now, in thinking about the plan, next slide, we identified 5 guiding principles, 9 key response pillars, and 8 implementation strategies. I think the guiding principles include a unified approach that explains why we are bringing all partners in a single plan to work together, a country-driven process that builds on the priorities that you have already identified yourself as a member state, an evidence-based response that really builds on the science, an equity focus that also targets the most deprived, and finally, a sustainable response that focuses on long-term solutions that can stay beyond the intervention of this plan. In terms of the response pillars, we have 9 of them that include the coordination and leadership at all levels, at continental level, at national level, and subnational level. The risk communication and community engagement, which remains a major pillar in the absence of the medical countermeasures. The surveillance, the laboratory capacity strengthening for early detection, infection prevention and control, both at community and at health facility levels. The medical countermeasures, starting with the vaccines that we are talking about, but also diagnostics and therapeutics. the case management, that's very, very much integrated. That includes both the medical care, but also the nutritional care and psychosocial support, the continuity of essential services to ensure that there is no disruption in the context of the emergency response, and finally, the research and innovation, because there's a lot to learn, many questions that are not yet answered when it comes to the Mpox outbreak. Now, in terms of the implementation strategies, 8 of them. The first is to establish one functional coordination structure with one team, one plan, one budget, one M&E framework at continental level, but also at national and subnational level. And the second strategy is to engage communities, especially the most vulnerable populations, to practice the key public health recommendations and access the needed services when they need them. The third strategy is to enhance surveillance with quality data, active case funding, and contact tracing. And the fourth is to strengthen, the most important, to decentralize laboratory capacity for testing to the subnational level, given the difficulties of the sample transportation in most of our countries. The fifth is to improve infection prevention and control measures at both community and health facility level, including building the skills that are needed, providing the equipment and supplies, and also establishing the wash facilities. And the seventh is to support an integrated case management approach that is really holistic in nature, with isolation facilities for those that are critically sick and need isolation. And the eighth is the ring vaccination, targeting the most at risk health workers that we talk about, and also the contact of confirmed cases, targeting also the most vulnerable, those that are immunocompromised, HIV, malnourished, and finally, the key populations because of unsafe sexual practices. And finally, is the coordination of the research to improve access to medical countermeasures and better understand the epidemiology of Mpox. Next slide. Now, what is most important this time is this new continental approach to emergency preparedness and response in Africa. That will make the difference. I think the content of that is 4 main things. One is this concept of one team, starting at continental level, but this time that is going to be co-led by WHO and Africa CDC. And then secondly, is to recognize the comparative advantage of different partners that always support our emergency responses in the wake of the different work streams, so that them also can lead in areas that they are the best in town in terms of the expertise and the resources. Now, the second point is the one plan concept, which is really this time the product of co-creation. I think all of you did receive the draft plan, and we are receiving very constructive input. And this is critical really to harmonize and align, our effort to ensure that there is a complementarity instead of wasting the limited resources. The fifth is the one budget, which is really consolidated, putting together the budget of the member state and also the budget of the different partners that are intervening. And finally is one M&E framework that with harmonized public health measures that are used by all stakeholders to monitor the progress that we are making in addressing the Mpox outbreak. Now, what does that mean in practice? We are just giving an example here. Let's move on to the next slide of how we see the functioning of that single continental incident management team. At the coordination level, we have Africa CDC and WHO co-leading. At the operations level, it's also Africa CDC and WHO co-leading. But in the different pillars of the response, we try to identify the organization that has got the comparative advantage over the others. For example, on communication, risk communication and community engagement, where UNICEF will lead in that area. but all of us, WHO, Africa CDC, USAID, CSO, IFRC, will be also support partners in that space. On surveillance, we know that WHO has a comparative advantage on lead that. On laboratory, Africa CDC will lead with the support of WHO and other partners. On vaccines, UNICEF will lead with Africa CDC, WHO, Gavi, and others. On case management, Médecins Sans Frontières will be the lead with the support from WHO, Africa CDC, and other partners. And on IPC, WHO will lead us. The same when it comes to the logistics, I think the leadership will be given to the World Food Programme, but with support from UNICEF and other partners. On planning, Africa CDC, and then on research, it will be CEPI with the support of Africa CDC, WHO, the US CDC. Just to give you a clear demonstration of this working together into what it translates, when it comes to the incident management team. Next. And we also have pulled together the numbers to try and understand the ambition of the budget that we are looking for. I think we've come to the first estimate of 245 million that are needed, of which 80% of that for the member state and 20% for the partners. But we've also looked at the money that's available. On the side of the member state, we just had the government of the Democratic Republic of Congo that decided to put $10 million to support the outbreak. And also at the AU level, Africa CDC received an approval of 10.4 million. That's about 20 million that are already available, and then we continue with the resource mobilization and we'll be updating these figures. Now, the current gap where we stand today is about 224 million we are looking for. But I would like just to also put a caveat here that we're receiving comment and input from different member states and partners until last night, which means that by Friday when we launch this report, there might be some slight adjustment, including on the budget that I've just presented now. And finally, just wanted to give also an update on the state of the response on the Africa CDC side, that we have set up this one continental incident management support team whose headquarters is in the DRC because of the simple fact that that's the epicenter of the outbreak. It's a 24-member team that's already there, and we are expecting 6 members from one organization this week, and many other organizations are also sending their representative to be based in Kinshasa with the team. On the funding side, as I said, 20 million already secured, and the mobilization continues. On the surveillance and laboratory testing capacity strengthening the member state, we just completed the training of 7 affected member states in sample collection, diagnosis and sequencing in Kinshasa. We are deploying 72 epidemiologists to the affected member state, and we are also supporting the decentralization of laboratory capacity with over 20,000 cartridges that are being distributed in the member state. On the mobilization of vaccines, we signed an agreement with HERA and Bavarian Nordic for an initial donation of 215,000, but we heard the DG when he was addressing updated that number to say that we have now France, we have Germany, we have Spain, we have the US that are all pledged to donate Mpox vaccines now, bringing this number to 1 million doses that are donated at present, and that continues. And in addition, I think the discussion of Bavarian Nordic indicate that they are very much willing to boost the production this year to deliver at least 3 million doses and another 7 million next year to reach the target of 10 million doses delivered by the end of 2025. And finally, on the coordination of the research, Mpox research, tomorrow in Kinshasa there's a continental R&D conference that is being organized to address the knowledge gaps in medical countermeasures. Your Excellencies, distinguished guests, thank you for your attention.
Thank you very much. You've heard from the experts about how we're driving collective MPOX action. The technical updates were thorough. You've seen the work that is ongoing at country level. We've heard that there is a broad spectrum of work being done, including training in diagnostics and screening, working with regional institutions like Institut Pasteur. You've heard about the combined action plan. And now it is time to hear from their excellencies, ministers of health. I said earlier that Africa must be master, mistress of her own destiny. And so, as we hear from ministers of health, your excellencies, we as a continent must continue to call on our leaders to invest in our own health systems. These cannot be left wanting. As those of you who have heard me say this before, I continue to call on you all to meet the obligations, please, set out in the Abuja Declaration of over 22 years ago. I would now like to, as I've noted the importance of national sovereignty, also note that member states are at the very heart. It is you that WHO serves. It is you that Africa CDC serves. And therefore, we want to invite, keen to hear from ministers of state from 3 MPOX affected countries particularly. And we will hear first from His Excellency, the Minister of Health of the Democratic Republic of Congo, who will speak with slides, I'm told. Your Excellency, the floor is yours.
Thank you very much for giving me the floor. Director General of WHO, Regional Director, Director General of Africa, CDC, thank you for reporting on the situation of MPOX. I will not enter into all details. We have adopted the same plans on country level in the Democratic Republic of Congo. The first case of MPOX was detected in a 9-month-old child. That was in 1970, and this is important because back then everybody was vaccinated and therefore the disease wouldn't spread back then. Everybody was vaccinated. This epidemic in 2022, it quickly resolved through the measures taken. These measures, we think we need to take them up again in a symmetric manner. I said already, in 1970, we had the first case, but this case did not lead to contamination among people around the child because everybody was vaccinated against smallpox then. That is very important, therefore, for us to have sufficient vaccines. Here you see the development between 2022 and 2024. I will sum it up with the following slide. If you look at the cases at the bottom right-hand side, 2022, there were over 5,000 cases, and 2023 there were about 4,000, and now we have more than 17,000 cases. So you see a progression, a very rapid progression of the disease and of the number of deaths. The fatality rate has increased. The case fatality rate has risen from 4.5% to 7.4%. If you look at the province Sud Kivu, and you see that on the table on the left-hand side, here you see the progression from more than 600 cases. That was the week 33. There have been 5 deaths. And this information gives us 2 elements of information. We need active case management. We need active surveillance to detect as many cases as possible and to detect them at an early stage. The fatality rate can then be quite low, as you can see on this table, and we need to insist on the importance of surveillance and rapid detection and case management. Case management is crucial. Next slide. You see in the Democratic Republic of Congo that there is quite an important spread around the forest area. You see that the epidemics and the cases are mainly observed around the equatorial forest, where the ecosystem is quite favorable to the spread. It has to do with the wildlife, monkeys and other animals, and this leads to the spread of the virus in the west. You see that red area, which is clade 2, which was already mentioned before. The researchers need to help us, and the epidemiologists need to help us, why there is this distribution in the center of the country and around the equatorial forest region. When you look at clade 1 and 2, you see that 1b circulates in particular in North and South Kivu, but there was also 1 case detected in Kinshasa, and 1a circulates in the rest of the country in the other 22 provinces. We have a capacity of detection and diagnostics with 2 laboratories, one in Kinshasa and one in Goma. These are NRB laboratories that allow us to make diagnostics. But we have the help also with cartridges being provided now, and we have gene experts that help us and allow us to facilitate the diagnostics as close as possible to the identified cases. Next slide. With regard to the plan, I will not go into too much detail because it is the plan that already has been presented by Africa CDC and that we have adopted also in our country. We have a unique type of coordination, 1 plan, 1 budget, and 1 coordination. And we have understood also the importance of risk communication and engagement of the communities. What is particular is that we didn't have a systematic community channel, but we now have a community relay, mediators of the communities that help us with the epidemiological surveillance on community level. And we also have case management. We also have a holistic approach that also involves psychological factors. We want that people who are sick come to us, present themselves. Of course, we do not want them to escape. The treatment is free of charge. We also have an appropriate logistics that we are working on, and we need, of course, vaccines. We have the support of the European Union, and also thanks to Africa CDC and other partners. 215,000 doses of vaccine have been pledged. Nigeria has already received 5,000. I don't know how they have done that. We are still waiting. We have also a promise from Japan, from the US, and with the emphasis on the vaccination of children. We have control measures in place that have been adopted. The impact of the transmission of MPEX is started to be noted. We have a lot of early detection with a positive impact and outcome, and with a decrease of the fatality rates. We also look at key populations. Programs like the fight against HIV/AIDS plays an important role with that regard. And with our vaccination strategy, we first want to vaccinate frontline health workers, key populations, sex workers, and people having sex with men. And also in the affected regions, we target children between 1 and 17 years of age. 1 and 7 years of age, and people that are in contact with confirmed cases. Our objective is, and you will see that on the following slide, we have two objectives: to interrupt the transmission chain and reduce the fatality rate. And we look at different vaccines, as says Inuit from Japan, and another vaccine. And this is what we are doing currently in the Democratic Republic of Congo.
Merci beaucoup, Monsieur le...
Thank you so much, Honorable Minister.
Incredible work being done. I would like to congratulate you on the work being done at the very epicenter of this outbreak in Africa at the moment. I'm going to move very quickly on, as we're running out of time, to the Honorable Minister, His Excellency, Minister of Health for Burundi. You have slides, I believe, and if I may remind all presenters that you have 5 minutes. Thank you very much. Can we have the slides up, please? The floor is yours. Oh, he wants to come up. Okay.
Merci.
Thank you, Madam Moderator, for giving me the floor. Excellencies, Ministers, the Director General, Regional Director for WHO Africa, honorable guests, all protocols observed, good day. It is a singular honor to represent the Honorable Minister of the Republic of Burundi to give you a report on the Mpox outbreak in Burundi. Burundi declared the very first cases of the Mpox disease on the 25th of July, 2024. Till date, till the 25th of August, the total number of suspect cases to the tune of 820, amongst which 702 were investigated and validated, 10 are awaiting investigation. And the total confirmed cases of the Mpox disease are 241 cases in 1 month. Overall, 29 health districts out of the 49 we have are affected by this disease. And it is worth noting that the positivity rate is 37.7% out of 622 cases that have been tested since the 150 were positive. Despite this alarming news, the good news is that Burundi has not yet witnessed any death due to the Mpox disease. And we have 38 cases that have been freed or declared free with delicate management. Next slide, please. This is what I was saying. Back, please. Back again. This is what I was saying. An overview of these two curves. The whole of Burundi is concerned by this disease. And we should bear in mind that the age ranges that are most affected are children under 5 years of age. And there are these under 5 ages that are most affected with a proportion of or ratio of 49%. The means of transmission is not yet known, but the test carried out in the laboratory, our national laboratory in our public health, enabled us to isolate the MB virus. We have not yet conducted studies to identify the main means of the Mpox disease transmission. But as we are sensitizing the population, we refer to the literature. We refer to literature that is recommended by WHO. What are the public health measures that are being carried out? We have developed and validated a response plan for the Mpox outbreak that will cost 14 million USD over 6 months, and it has taken into account the One Health approach, because when we developed and validated this plan, all our partners and the stakeholders were present. WHO, UN agencies, as well as the other ministries, such as the Ministry of Environment, Livestock and Fishery. And there is prompt response from the government to fund this plan. And in our plan, or the plan that was published, we were able to raise $1 million to accelerate the management of these cases. We equipping our reference laboratory to be able to identify the different mpox cadres. And we are working, bending over backward to give briefing so that our physicians are equipped on mpox management. We should bear in mind that management is free for all patients. We take into account our national protocol, which has been set up. Management is free with the support of our partners such as UNICEF, PAM, and Doctors Without Border. We are strengthening our health districts with investigations, alerts, notification of diagnoses, and the management of cases. The deployment of surveillance teams for investigations, research, tracking, and follow-up of contacts. Prevention is based on disseminating sensitization messages. Immunization has not been rolled out yet. We are proceeding to disinfect the affected homes in the most vulnerable neighborhoods. We have a slide, for instance, in Bujumbura, our economic capital. We have part of a town that is highly affected due to hygiene, precarious hygiene conditions. What are the major challenges we face? Mainly linked to the financing of the plan for a coordinated response touching all the pillars, especially epidemiological surveillance, diagnosis, because currently we are carrying out tests in our reference laboratories that are equipped with tailor-made equipment. We have a real need to decentralize the diagnosis in our hospitals by strengthening them, using cartridges, given that most of these structures are equipped with expert equipment. In a nutshell, Burundi has been sparing no efforts to combat mpox with prevention and surveillance and diagnosis methods. We have a political engagement as soon as the outbreak was declared, and we want to salute the promptness and the proactivity of the WHO via its WR and Africa CDC that has been working with the Ministry of Health of Burundi, as well as the mobilization and the coordination from other partners and other UN agencies in Bujumbura. Once again, I would like to deeply thank them for that. Moreover, or all the same, we need additional support to strengthen our preparedness, diagnosis, and financing of the response plan that has been developed. We are appealing for a collaboration from our continental and regional partners, especially with our brother countries, our neighboring countries, for relentless surveillance, for dissemination of information. Thank you, Madam Moderator.
Merci beaucoup.
Thank you so much.
Very quickly now to the Honourable Minister, His Excellency Dr. Aaron Motsoaledi from South Africa. I welcome you now to make your statement. Please do remember you have 5 minutes. All of you, this session is standing in between you and lunch. So if we can please make sure we have enough time for questions and answers. Your Excellency, it's yours.
Thank you, ma'am. I also have slides I can present from here if the Secretariat can move the slides. Yes. Thank you very much. Can you go to the next one? No. Yes. Yeah. Mpox started in South Africa in 2022 with 5 unlinked cases of male having sex with males In 2023, there were no cases. In 2024, there are 24 lab confirmed cases of Mpox. In 3 of our 9 provinces, they are associated with clade 2B. Next. That is just a graph showing the extent in South Africa. Next. The summary here. Next slide, yes. Our summary is that out of the 24 laboratory confirmed cases, 12 cases, just 50% are in Gauteng province. That's where the capital city is. 11% are in the province of KwaZulu-Natal, and one case, 4% in Western Cape. That's where Parliament is. All cases are male, age range between 17 and 43 years old, median age 33. The earliest recorded date of onset of symptoms of the 24 cases is 15 February 2024, and presently all 22 cases of these 24 have all completed contact tracing. That is 92% of the cases. Next. For where details are known, 16 cases, that constitutes 67%, had underlying medical conditions. They were all HIV positive, either with unmanaged or recently diagnosed disease. 11 cases, or 46%, self-identified as men having sex with men, and 5 of them, constitute 23%, had access to tecovirimat through SAPRA. SAPRA is the South African Health Product Regulatory Authority, the medicine regulator in our country. And Section 21 means drugs that have not been regulated or registered but are given on compassionate basis through Section 21 of the SAPRA Act. As we said, 3 Mpox-related cases have died. That is a 13% case fatality rate. Just to give you a summary again there, 19 people have recovered, 3 have died, 2 are still active, 5, as I said, received tecovirimat, and the total is 24. On the issue of leadership, we're just showing that Mpox is now a notifiable medical condition in South Africa. Community health, healthcare workers have to report if they get a suspected case. They must report within 24 hours. Can you move? Yes, next slide, next slide. Next slide. Yes. Epidemiological and outbreak response investigation were initiated. 700 tests have been performed in both public and private because we think we have got capacity to do so. Next slide. Maybe I can leave that one. Case management, next. Cases have been isolated in hospitals or at home with effective, infection prevention protocols being done. Can we move to the next slide? On communication, risk communication and community engagement, the strategy has been developed to reach high-risk populations with Mpox messages, working with relevant. Can you move? No, I'm not yet there. Unfortunately. Okay, maybe just to mention that we're working with stakeholders. The next slide, which is there, just summarizes the laboratories. Pathcare, Lancet, and Empath are all private laboratories. The last one there, which is public, NICD, is our National Institute of Communicable Diseases. They've done most of the tests at 458 tests done by them. Next. Yes, I'm there now, showing that there is not much difference between male and females in as far as the tests were performed. Red is pink there is female, blue is male. Next. Let me skip that one. Can you go to the next one? Yes. Our request to the international partners, is tecovirimat access through donation from WHO, ongoing support with access from WHO should the increase, the need increase. At the moment, South Africa requires 40,000 vaccine doses for high-risk group for pre and post exposure. Next, additional technical assistance is requested from WHO